Guys, I'm back with another video on etiology and management of midline diastema in children. It is a 7-marker question in the subject of periodontia in final year BDS. Before starting with the etiology, let's see the definition of midline diastema. It has been defined as a space in full permanent dentition that is greater than 0.5 millimeters between the proximal surfaces of adjacent two incisors. The first etiology can be transient malocclusion, which is a self-correcting anomaly. It will be discussed further in the upcoming slide. The second etiology can be tooth material arch length discrepancy or unerupted mesiodens or abnormal frenal attachment, proclination as a result of habits such as thumb sucking and tongue thrusting, midline pathology like cysts and tumors, racial predisposition most commonly seen in negroids, and ectopic maxillary canines. Management of midline diastema can be done in 3 phases, which includes removal of cause, active treatment, followed by retention. Removal of cause. The first phase involves removal of the etiology. Habit should be eliminated using either fixed or removable habit breaker. Now let's talk about the treatment plan according to the etiology. First being the ugly duckling stage, which is seen in normally developing dentition. It is self-correcting after the eruption of permanent canines. Spontaneous closure seems to occur with less frequency in cases of generalized spacing and initial diastema of more than 3 mm. Familial incidents can be treated by appliance therapy. Parafunctional habits like flaccid lips and a poor muscle tone, simple tongue thrust may cause anterior open bite and diastema. Thumb or digit sucking over a prolonged period can also cause midline diastema. Correction of the habits has been known to spontaneously correct the diastema within limits. In cases of excessive diastema, correction of the diastema can be simultaneously carried out with the habit-breaking appliance. In cases of tooth size discrepancies, where there is excessive anterior vertical overlap, excessive vertical maxillary alveolar growth, retrognathic mandible, or a prognathic mandible. It can be treated by first intruding the maxillary incisors, followed by retraction of the incisors to close the diastema. If, however, cephalogram indicates an excessively long lower phase or a class 3 growth trend, functional therapy may be the treatment of choice. In cases of frenum attachments, generally advocated that the diastema should be closed as far as possible before going in for frenectomy. The reason cited is that should the surgery be performed before the surgical scar tissue maintains the diastema. In cases of mesiodistal angulation of teeth, the correction of the crown angulation or tipping will close the diastema. In cases of tooth anomalies like supernumerary teeth, peg-shaped laterals, absence of lateral incisors, can be treated by removal of the supernumerary teeth followed by a closure of the diastema. Peg-shaped laterals can be corrected orthodontically followed by aesthetic restoration of the peg-shaped laterals. In cases of absence of laterals, the space for the missing laterals, if detected early, may initially be maintained and at later date replaced with fixed prostheses. Another option is to orthodontically move the canines into the space of the missing laterals, followed by a careful recontouring of the cuspid and the first bicuspid if required to stimulate the lateral and cuspid respectively. Pathological or juvenile periodontitis can be treated by systemic phase if required, followed by appliance therapy. Second phase involves the active treatment. It can be done using removable appliances or fixed appliances. The principle applied here is of reciprocal anchorage. The types of movement are either bodily or more commonly by tipping. Removable appliances. A modified Hawley appliance can be utilized for this purpose. The plate incorporates two palatal finger springs distal to the central incisors. Springs are made from spring-hard stainless steel wire of 0.020 dimensions. The helical are incorporated to enhance range of the movement. The spring arms are placed as close to the gingival margin so that when activated being close to the center of resistance should move teeth with minimum of tipping. A split labial bow is a modification that can be utilized to close the diastema. Inherent in the use of removable appliances is the drawback that only tip-in movements can be achieved. For optimum angulation of the teeth, a further correction is required with fixed appliance. Coming to the fixed appliances, a 2x4 appliance is used to close the diastema and move the anterior four incisors towards the midline. This appliance can also help in the correction of rotations, labial tipping, and intrusion if required. Bonded pre-adjusted appliance is excellent choice. Once the active treatment is over with lighter forces, final tooth and root positioning is done with full-size stainless steel wire that is left in brackets for at least 2 months prior to debonding. The closing forces can also be generated with use of elastics, band or thread. A stainless steel band with a bracket or more commonly a bracket may be bonded on each of the incisor. A sectional wire is ligated. Elastic band is utilized to bring the central towards each other. For a more aesthetic treatment, a lingual button may be bonded and elastic applied. This mechanism also brings about only tipping movement and not true bodily movement. Last is the retention. In order to prevent relapse, a long-term retention is required in these cases. A small multi-stranded flexible fixed spiral wire is bonded and usually retained for years. Thank you for watching this video. If you like this video, please subscribe to my YouTube channel. Stay tuned for further videos.